Janet wants to know what factors enable a patient to achieve and continue in remission if they are not able to receive stem cell transplant due to age restrictions.
So I think first and foremost, I think it's very important that that patients are aware that there shouldn't be just stringent cutoffs of age as a requirement for stem cell transplant. And really, there's a lot of research going on that we should take into account physiological age, and there's ways to measure that, just to be sure that stem cell transplant really is not an option. And for patients whose stem cell transplant is not an option, I think, as we talked about earlier, so there can still be, really great treatments that can get patients into remission, and ongoing therapies with dosing adjustments, again, to decrease toxicity, improve quality of life, and thinking about things like maintenance therapy as appropriate.
What are the age restrictions and why are they there?
So sometimes you will hear age 75. Really, no one above age 75 should move forward with transplant. And that's based off of past data where they've explored transplant and seen increased toxicity and from transplant in itself, increased side effects, increased risk of early mortality. And so I do think it's important to take the patient as a whole into consideration, because again, you could have someone who's 77 who may be running marathons and in great shape and not a lot of other healthcare issues, who may still do really well with treatment. And so I think that's really needs to be taken into account, really the overall picture of health for the patient before making just a firm cutoff.
Right. Okay. So it's not cut and dry.
Exactly.
If you're 75 or older, then you definitely can't have a stem cell transplant. Then you're looking at everyone individually.
Yeah, so it really should be looked at. And I still have some patients who will come to me and say, oh, I was told I'm 68 years old, I'm not a candidate. And that always makes me take a step back. And then we have to kind of have that discussion again. And they may still not be a good candidate based off of other, comorbidities or healthcare issues, but it shouldn't just be a number rules you out for having that as an option.
Good to know. We received this question from Carl. What does treatment look like following transplant? And what are doctors looking for when monitoring through blood tests?
Sure. So after transplant, the first 3 months is pretty intensive of being seen very frequently at your transplant center, twice to once a week. You're also on immunosuppressive medications to try to help prevent issues like graft-versus-host disease, which can be a complication from transplant. And then over time, if you're doing well, we try to start tapering off those immunosuppressive regimens to see if you can tolerate that. And what I tell most of my patients for who are undergoing transplant, it can take some time to really feel back to being yourself. It can take 6 months, it can take a year or longer. And sometimes your normal is a new normal based off of how you do and the side effects of the transplant in itself. So you may not all get back to if you're here before transplant and before your diagnosis, it may be that this is your new normal. Just so people can, be prepared and know what they're kind of signing up for.
And with the blood testing, what are you looking for when you're monitoring a patient?
Sure, there are a few different things that we're looking for when monitoring patients. So one, making sure that the stem cells or the graft from the donor are recovering. You want to see that blood counts, levels of white blood cells, red blood cells, platelets are getting to normal levels. You're also assessing and making sure you're not seeing signs of relapse. You're checking levels of donor cells versus the patient cells within the stem cell compartments. And so we're taking all of those into account, as well as checking organ function to making sure there's no signs of potentially graft-versus-host disease as well.
Brian wants to know, I'm a year and a half post-transplant. How can you tell if the aches and pains in your joints are normal aging, host versus graft disease, the AML returning, or even something else?
So that's I was so I think that's also a difficult question to answer because it really is patient dependent. And so I think if you're having new joint aches or pains, it's always important to reach out to your transplant team to make sure that it could be any of the above. And so you're getting the appropriate workup, with lab work, imaging, things that would be appropriate, or seeing certain specialists, maybe orthopedist, if needed, because it could be, I'd say less likely leukemic relapse, but still want to be sure. But it could be definitely complications from GVHD, or, there's some joint issues that can evolve post-transplant, especially for people who are on long-term immunosuppressant medications, or it could be the normal effects of aging. So it's always good to have that reassurance.